70% of counties in the United States do not have a single practicing endocrinologist. And that one statistic explains why millions of people are walking around with a life-threatening hormonal condition they think is just severe burnout. When you don't make enough cortisol, your body literally cannot respond to stress, but because the symptoms look like a dozen other things. The average patient waits months, sometimes years, just to get a name for what's wrong with them. And depending on your zip code, finding someone who actually knows how to treat it might require crossing state lines. Lily, we're looking at a massive structural failure here, but it's playing out in total silence.
It really is, and there's something almost sad about how quietly this happens. Because if you think about adrenal insufficiency, and whether we're talking about Addison's disease or secondary adrenal insufficiency, it's this invisible unraveling. Cortisol is the hormone that manages your blood pressure, your blood sugar, your fluid balance. When a healthy person gets into a car accident or even just catches the flu, their body floods with cortisol to manage that physical stress. But for someone with adrenal insufficiency, that mechanism is just broken. It's gone. And what that means on a practical level is that a standard stomach bug can escalate into a fatal adrenal crisis. But before you even get to that crisis, you have these vague, creeping symptoms. Fatigue, weight loss, dizziness, maybe some nausea. So you go to your doctor and they say, well, you're stressed, you're working too hard. Or maybe you have an eating disorder. Actually, there was a study looking at diagnostic delay where they found that fewer than 30% of women and 50% of men with adrenal insufficiency are diagnosed within the first 6 months of symptoms. 1 in 5 wait over 5 years. 5 years of your body slowly forgetting how to keep you alive, and you're just being told to rest.
5 years is a structural problem. That's not a single missed lab result. That is a healthcare system that is fundamentally misaligned with how this disease presents.
Right, and it's because the symptoms don't scream endocrine failure in the early stages. The clinical presentation is so nonspecific. You leave one appointment with a prescription for an antidepressant and another appointment with a referral to a gastroenterologist because your stomach constantly hurts. And every specialist is looking at you through the lens of their own discipline. It's the classic blind men and the elephant scenario. Nobody is zooming out to look at the whole picture, mostly because primary care doctors are strapped for time and don't have the specialized training to spot the subtle interconnectedness of a failing HPA axis, the hypothalamus, pituitary, adrenal feedback loop. So the patient just languishes in this diagnostic purgatory.
I want to pause on that, though, because it's easy to look at a 5-year diagnostic delay and say the system is incompetent or doctors aren't paying attention. But wait, is it actually reasonable to expect a general practitioner to catch this early? If the symptoms are just fatigue and nausea, that's literally everyone who walks into a clinic in February.
I don't know, that feels too clean to me. I hear you, but I keep getting stuck on the fact that we have tools to test for this, and they just aren't being used until the patient is practically comatose. Yes, fatigue is common, but severe, unremitting fatigue accompanied by unexplained weight loss and a drop in blood pressure should trigger a basic morning cortisol draw. It's a cheap, accessible blood test. The issue isn't just that the symptoms are vague, it's that endocrinology as a field has been heavily siloed. The availability bias is huge here. A doctor sees a tired teenage girl who has lost weight and their brain jumps to an eating disorder because they see that all the time. They don't jump to Addison's disease because they've never seen a case of it in their entire career. And that gets back to your opening statistic about the sheer lack of specialists.
Right. We have something like 8,000 practicing endocrinologists in the U.S., and a huge chunk of those are doing research or working in industry. The ones seeing patients are clustered in major coastal cities. If you live in rural Ohio, your access is basically zero.
Exactly. The geographic disparity is staggering. If you look at the data, for adults aged 18 to 64, the population to endocrinologist ratio within a 20-mile radius is nearly 30,000 to 1. Think about that. 30,000 patients competing for one specialist's time. And in rural areas, it's even worse. So what happens? You have a patient with a highly complex, nuanced condition, a condition that literally requires emergency protocols, stress dosing of steroids, and precise medication adjustments. And they have to drive 3 hours each way just to see someone who understands how to manage it. This geographic trap means that even if you somehow manage to get a diagnosis, surviving the disease day to day becomes a logistical nightmare.
And that forces a shift in how care is delivered. If the doctor isn't in your zip code, the zip code has to stop mattering, which is where telehealth steps in, the hybrid model.
Yes, and this has been one of the most fascinating shifts in the past few years, because endocrinology actually adapts incredibly well to virtual care in certain respects. Unlike orthopedics, where they need to physically manipulate your knee, a lot of endocrine management is pattern recognition. It's reviewing lab results, tracking symptom diaries, adjusting steroid dosages based on life events. So we're seeing this hybrid care model emerge out of pure necessity. A patient in a rural community will use a platform to have a virtual appointment with an endocrinologist in a major city. That specialist sends electronic lab orders to the patient's local hospital or Quest Diagnostics. The patient gets their blood drawn locally, the results go back to the specialist, and they manage the care remotely. It bridges the gap. It's not a perfect system, obviously, but for someone who previously had no access at all, it's a lifeline.
But wait, does that actually hold? Because you're managing the chronic side of it beautifully. But adrenal insufficiency isn't just a chronic condition. It's an acute one. If that patient crashes, they aren't logging onto a Zoom call. They're going to the local ER.
Actually, no, you're entirely right, and that is the terrifying blind spot of the telehealth model. You cannot virtualize an adrenal crisis. If you get into a car accident or contract a severe infection, your body goes into shock because you have no cortisol. You need an immediate, massive injection of hydrocortisone. The remote endocrinologist can't do that through a screen, so the patient is forced to rely on their local emergency department. And this is where things get genuinely unsettling, because local ER doctors in these underserved areas often have very little experience with adrenal crisis. Patients report showing up at the ER with a letter from their endocrinologist detailing exactly what to do, administer 100 milligrams of IV hydrocortisone immediately, and the local doctors will argue with them or insist on waiting for lab results first, which can be fatal. Telehealth solves the day-to-day management, but it absolutely fails to protect the patient in an emergency if the local infrastructure is uneducated about the disease.
So the patient is essentially carrying the burden of educating the very emergency room that's supposed to save their life. That is an incredible amount of pressure.
It's an immense burden, and it speaks to the broader issue of fragmented care, which doesn't just happen in rural areas. Even in cities, patients with complex conditions often find that their symptoms don't fully match what any one specialist expects to see. Adrenal insufficiency rarely exists in total isolation. It often overlaps with other autoimmune conditions, thyroid disorders, neurological issues. So you end up with a rheumatologist, an endocrinologist, and a neurologist, none of whom are talking to each other. You leave an appointment with part of an answer, but you know intuitively that something still doesn't add up. And that uncertainty is exhausting, which is why there's been this massive surge in online second opinions from major academic medical centers.
Let's dig into that. Cleveland Clinic, Mass General, Stanford, they've all built these virtual second opinion programs. You submit your records, and a subspecialist reviews your entire case remotely. It's essentially buying a fresh set of eyes.
Exactly. And the numbers backing up the necessity of these programs are wild. The CEO of the clinic by Cleveland Clinic noted that 12 million adults are misdiagnosed annually in the U.S. In the first 18 months of their virtual second opinion program, 72% of cases resulted in changes to the patient's treatment plan. And 28% of the time, there was a complete change in diagnosis. That is staggering. Over a quarter of the time, the original diagnosis was just wrong. When answers stall locally, this provides a mechanism to bring in world-class subspecialty expertise without having to get on an airplane. You upload your labs, your imaging, your doctor's notes, and a dedicated coordinator organizes it all. Then an expert, someone who specializes specifically in complex adrenal and pituitary disorders, not just a general endocrinologist, spends time reviewing the whole picture. They write up a comprehensive report. Sometimes there's a virtual consultation. It pulls all those fragmented pieces of your medical history into one cohesive narrative.
I'm not sure that holds up as a scalable solution, though, because we're talking about out-of-pocket costs. Cleveland Clinic charges around $1,850 for some of these comprehensive virtual reviews. That creates a two-tiered medical system where clarity is a luxury good.
I hear you, and that makes me genuinely uncomfortable too. The equity issue is massive. If you have a high-end corporate job, your employer's health plan might cover the cost of a virtual second opinion as a premium benefit. But if you're underinsured or paying out of pocket, $1,850 is an impossible hurdle. At the same time, we have to look at the cost of being sick and misdiagnosed for years. The total cost of unnecessary services and inefficient care due to misdiagnosis in the U.S. is over $300 billion annually. Patients lose their jobs because they are too fatigued to work. They pay for dozens of copays, useless medications, and travel to local specialists who don't help. In that context, $1,850 to finally get the right answer and a functioning treatment plan might actually save the patient money, and, more importantly, save their life. It's a broken system that forces patients to buy their way to clarity, yes. But until we fix the geographic distribution of specialists and the underlying training deficits, these virtual second opinions are acting as a vital safety valve for complex cases.
So we're relying on privatized workarounds for a systemic structural deficit. The patient becomes their own project manager, coordinating local blood draws for a specialist 3 states away or paying $2,000 to have someone connect the dots.
They have to become project managers. And I think that's the most profound takeaway for anyone navigating adrenal insufficiency or really any complex overlapping medical condition. If your symptoms don't make sense or your condition feels more complex than the single explanation your local doctor gave you, wanting clarity isn't overreacting. The system is designed to look at you in pieces, seeking out a broader view, whether that's through a telehealth specialist, an online second opinion from a major center, or just relentlessly advocating for a different diagnostic lens, is sometimes the only way to move things forward. When answers stall, it doesn't mean the answers don't exist. It just means the person you're asking might not have the right map. Second opinions don't guarantee immediate clarity, but they open doors that simply weren't visible before.
And sometimes that shift is what finally pulls you out of the dark. We've been looking closely at the care gaps and diagnostic hurdles surrounding adrenal insufficiency and complex chronic illness, drawing from the real-world frameworks outlined in My Adrenal Life.
It's a heavy subject to sit with, but understanding the mechanics of how this care is accessed is the first step toward getting better.
Send this episode to someone who's currently stuck in the medical system looking for answers. It might be exactly the permission they need to look elsewhere.